So good afternoon. I think we can start this session that is a very special session to me for a number of reasons. Some are personal, so I won't share them. But I think it is a great opportunity to really learn more about polymer technology, which is so important in driving and improving outcomes of patients who receive devices. So the session is entitled Introduction to Polymer Technology, What is Relevant for the Interventional Cardiologist. So we have a wonderful faculty for this session, and they commit to actually teach us what we need to know, which I guess is really what we want. So the objectives really are to learn more about the differences between the polymers that are being used on current generation drug-eluting stents, to understand how the polymer may modulate or change the biologic response, the interaction with the hosting tissue, and of course to understand the impact that different polymers may have on patient outcomes. So I have the great pleasure to co-chair this session with Dr. Virmani. And actually, this session was made possible thanks to a collaboration and a grant from two companies, CVPath, or CVPath is actually not a company, it's a non-profit research organization. And about everything you see, or most of what we see in pathologic evaluation of preclinical or clinical data comes from CVPath and Abbott. So thank you for that. And without further ado, I would like to invite Dr. Ratner to tell us about what happens when you put biomaterials in contact with blood. Thank you.
Okay, well, good afternoon. I like the name of the session, What is Relevant for the Interventional Cardiologist. What is relevant is that polymers are, in my opinion and based on my data, always going to be more blood compatible than bare metal stents. That's what's relevant. Now, the rest of my talk is what's irrelevant for interventional cardiologists, but I'd be glad to give you my irrelevance. So let's see here. Yeah, so conflict of interest. The research funding for some of this did come from Abbott Vascular, but we've had research funding from the US NIH for 30 years before Abbott Vascular came along. So let's see. Why am I talking on this subject? Well, this is a book from a 1969 meeting, one of the earliest large meetings on the subject of blood compatibility, and I was present at that meeting in Washington, D.C. I've been doing this for a long, long time, 40-plus years, and I've learned that in contact with arterial blood, hydrophobic or Teflon-like surfaces are less activating to platelets. I've also written a number of editorials and articles like The Blood Compatibility Catastrophe, to illustrate some of the confusion within the field. But I'm going to go back again historically to a paper. I worked for many years with Dr. Lawrence Harker, MD hematologist at the University of Washington. And Dr. Harker published this paper in 1972. And the conclusion was, in the venous system, we worry about fibrinogen and the transition to fibrin dominating thrombosis. But in the arterial system, platelets are almost totally involved, with very little involvement from the fibrinogen consumption. So right away we learned, given that the coronary arteries have arterial-like flow rates, or as we call them in engineering terms, the wall shear rate, then it must be the platelets we should be studying. And again, going back to it's probably 1978 or so, we published an article or a study using a baboon arteriovenous shunt, femoral shunt system. We used the baboon because we did a survey and found the baboon was hematologically the most similar of all the research animals to humans. And so within the shunt, there was a break, and then we could insert test segments and examine them. And the results that came out of this, it was a model developed in conjunction between hematologists and engineers. And we had a number called platelet consumption. That's platelets being destroyed by the material per square center of material per day. It's actually, again, in engineering terms, called a rate constant of reaction. It's a reactivity. And the early study we did, there was a hypothesis that hydrogels would be wonderfully blood compatible. What could be more blood compatible than water? So let's put more water into a hydrogel. And so we had water content on the x-axis in these materials versus a platelet damage. And much to our surprise, the results came out exactly the opposite from what we expected. The most hydrophilic materials were the most damaging to platelets. And if we go all the way down this curve, we find at the lowest platelet damage a very hydrophobic material, silicate, silicone rubber. So that was quite a surprise to us. And where the hydrophilic were platelet damaging, the hydrophobic were good. In a follow-up study, we looked at 4 rather hydrophobic polymers, all showed very low values of this number, platelet consumption. The hydrophobic polymers were very good, including Teflon in this set. The other side of that is that most metal surfaces are hydrophilic, and I do believe that hydrophilic surfaces are not very good in contact with arterial blood. So in another study, we looked at vascular prostheses. These were Dacron, and the lower one was fluorinated by a technology we have in our lab. And again, in the baboon model, the untreated was highly thrombotic. The fluorinated was actually quite clean. And we worried about it being embolic. We actually measured embolism rates, and the fluorinated was less embolic than the untreated. Again, the fluoropolymers look good. Those helped set our ideas and led us up to exploring what's called the fluoropassivation concept, which was published in a journal called Biointerfaces that published by a physics society that is very interested in the interfaces. So one of the general principles to understand this talk is an appreciation that within 1 second, a surface in contact with a proteinaceous medium like blood will be completely covered, totally covered with blood. The bottom line is the blood cells never see our biomaterials. What they see is proteins that absorb. And so the proteins that absorb are really driving the reactions we see. And my colleague Tom Horbit generated this very nice set of data looking at platelet interaction as a function of the key proteins within blood or within blood plasma. And so it's platelet adhesion he looked at. And notice the bovine serum albumin has essentially 0. There's no interaction with platelets. Fibrinogen, you might say, is the bad actor. It sticks and activates platelets quite enthusiastically. This is 1% human plasma, full plasma with all the proteins mixed in. And other proteins like fibronectin, for example, which is associated with cell adhesion, actually was quite inert to platelets relatively compared to fibrinogen. So the sort of a key hypothesis for blood compatibility, and again goes back to 1974, when Dr. Lyman published this study where he suggested that if one has high albumin concentrations, you have an area of non-thrombogenicity, low albumin concentrations are very active in platelet adhesion, release, fibrin formation. So people have been thinking a long time about this idea of albumin. And so we're going to take Dr. Lyman's 1974 hypothesis and sort of bring it up to date. And we believe that higher albumin to fibrinogen ratios on the surface are desirable. Albumin doesn't activate platelets, fibrinogen does. Let's get as much albumin as possible. And the ability of albumin not to be displaced by undesirable proteins is good, is desirable. One protein can push another one off, particularly larger proteins push smaller ones off the surface. The surface retains the albumin. We believe that will be good. So in the study, we tested 5 biomaterials. This polyvinylidene hexafluoropropylene polymer is the polymer that coats the Wijns stent, and the butyl methacrylate polymer and these 2 SIBS polymers are used on some of the competitive stents, and then we had 316 stainless steel also within this set. So one more point is that to measure the ability of that surface to retain the albumin, we looked at adsorbed and then eluted with the SDS, soap really, and measured the amount protein adsorbed, and then after washing with the SDS, how much remains as a measure of tightness, how tightly is the protein stuck to the surface. So the published paper we published in that 2016 issue of Biointerfaces had about 10 plots that were similar to this. The conclusions were the same on all the plots. I don't have time to show 10 plots. But the interesting thing, here we have adsorbed albumin, and also I put it in green, the ratio of adsorbed versus eluted. And so there's this ratio. So we have the white bar is eluted, and so about 2/3 of the protein came off. But in comparison to the other materials, this ratio is 3 here, 49, 23, 27, and stainless steel is 50. What they all mean is that all the albumin comes off and is eluted very readily, where a good bit of it is still retained on the fluoropolymer. Here's just some more. Again, these are about 10 different figures. I could have taken almost any one of them. And this talks about albumin in comparison with fibronectin in sort of a competitive study. But again, the green numbers are the adsorbed versus eluted. And so once again, we have a number 3 for the fluoropolymer, the polymer that is used on the Wijns stent, versus 60, 20, 35, or in another study, 2 versus 25, 19, 27, 100. In every case, every single case we measured, the fluoropolymer retained the albumin, and the albumin, the point is, albumin is good for platelets. So let's see, and I sort of emphasize those low numbers. So the general conclusion for this very short talk is that the fluoropolymer, the polyvinylidene fluoride, the hexafluoropropylene, consistently behaves in a very unique manner compared to all the other polymers used on stents. It typically binds more albumin and retains more albumin on the surface. The ratio of albumin to fibrinogen is high on this material, and there's more total albumin. And finally, the material binds fewer platelets, the fluoropolymer, with actually a small effect, and a very large effect. It bonds fewer of the monocytes, the precursor to macrophages, than other stent materials. And all this data is reported in the paper we have there. So I believe that's the end. So thank you very much for your attention.
The paper's open for discussion. Are there any questions? Go ahead.
Yeah, I start. So apologize for maybe asking a stupid question, but probably it is. But thank you very much for, giving us the crash course. So the biomaterial is there, then comes the protein by adsorption.
Yes.
And then comes the platelet on the protein. Is that receptor binding, platelet to protein?
The fibrinogen platelet interaction is receptor mediated, but there are no receptors on platelets that detect albumin. So that's for its blandness, if you will, for platelets.
Okay. And you know that our platelets, I mean, the platelets of patients undergoing intervention are, we give lots of drugs.
And they could be stimulated or they could be decreased, but the bottom line is fibrinogen there's very specific receptors in the integrin receptor on the platelet, and we have no such thing for albumin.
Thank you.
I have a question. The question is, we talk about albumin. What happens to albumin when you leave it on that surface? Does it stay, instead of you're washing it out, when you're leaving it in circulation, what happens to that albumin?
Yeah, it's a very good question. Very good question. So there have been a number of medical devices, particularly vascular prostheses over the year, where the companies have said albumin is good. Let's covalently immobilize. Let's tie down the albumin permanently to the surface, make a permanent albumin surface. And it was, I think, a reasonable idea, except what they found is that in long-term interaction in the bloodstream, the albumin gets degraded. The body has all sorts of great enzymes for breaking down old proteins. And so to go back to your question, what we think is happening is the albumin's on the surface. And I believe because the blood does have a high concentrate, the highest concentration protein is albumin, I think the surface is constantly renewed. I think albumin can displace albumin. We get constant renewal of albumin on the surface. And that accounts for the longer-term blood compatibility.
May I ask you, you showed the dacron with and without fluorine. Yeah. Fluorination.
That's right.
Was good. What led to that hypothesis? Was it just an observation or the use of fluorinated?
So again, the early studies we did showed that hydrophobic polymers look better than hydrophilic or wettable polymers. And what could be more hydrophobic than fluoropolymers? Fluoropolymers are, in fact, the most hydrophobic. So we tried it. We developed the technology in our laboratory to treat surfaces with hydrophobic fluorinated polymers.
So what happens if we coat that stent with bioabsorbable polymer? Are they PLLA, for example?
Yeah.
Is that going to be any different than as compared to fluorinated polymers?
Well, I do think PLLA, the polylactic acid, is more hydrophilic than the fluorinated polymer. It's actually relatively, again, the way we measure these things, the quantitative data is what we call contact angles. And polylactic acid has this methyl group in the background, and the methyl groups are pretty hydrophobic. So as polymers go, polylactic acid is on the hydrophobic side. On the other hand, it's not as if you will, blood compatible or platelet friendly or albumin friendly as the fluoropolymer. You know, another part of it, though, is there's a surface erosion that's constantly taking place. I sometimes like to think about how space vehicles used to re-enter the atmosphere and put on the heat shield an erodible polymer, and as it came down through the atmosphere, the heat, the erodible polymer just evaporated away. Well, to some extent, the polylactic acid is constantly very slowly degrading, particularly at the surface where the hydrolysis takes place. And the surface may be sort of, we might call it unstable in the early phases. So these are hypotheses, but could explain why we're getting pretty good performance from the polylactic acid. It's hydrophobic, it does undergo the surface degradation, and maybe that's why we see good performance there.
Can I ask another question?
Of course, of course.
The question is, are metals different from one another? Like stainless steel versus cobalt chromium versus platinum versus gold?
Well, platinum is very interesting. Platinum is about the only metal, pretty much the only metal that has no corrosion product at all in biological environments. Gold actually surprisingly corrodes relatively rapidly in biological environments. And in stainless steel, when we put them into protein solutions, we see actually very rapid nickel and cobalt release from these. The stainless steel, we know how inert it is, but in a protein solution, interestingly, we can easily measure metals given off. So most metals do give off metal ions. Many of these metal ions are well-proven stimulators of inflammation. And so in my opinion, about the only really inert metal is platinum in this environment.
One more question, if I may ask. You know, we are all being interested in grafts, and nobody has a graft which is less than 4.5 millimeter diameter. So what if we made a graft which was, say, 3 millimeter, but coated with fluorination? Would that make a difference? Could we keep that open?
Well, if we go to the classic Gore-Tex, which of course has so much clinical experience, it doesn't work. So, but you want the hypothesis that explains this. In essence, this polymer, all polymers, stimulate what we call the foreign body reaction. The body really puts a collagen sheath on these materials, and they're actually activated macrophages continuously on these that I think through the porous structure of things like Teflon just keep on giving out anti-healing or non-healing cytokines that are undesirable. It's why we don't get in humans, we do not get endothelialization on large surface grafts. The tiny struts of a stent, yes, the body can bridge those with endothelium, but we never see the endothelium on grafts. And this is leading us, within our group, this is a completely different subject, but we're developing what we call pro-healing grafts that totally bypass what we call the foreign body reaction, and we're hoping to someday solve that problem, the small diameter vascular graft. Very good question, though.
Any other questions from the audience? I'm the only one hogging everything. So not only does platelet aggregation, inflammation plays a very important role. On these surfaces, will platelet activation also activate the inflammatory cells?
I think there is a connection. So in flowing blood, the inflammatory activation is stimulated by released cytokines from the platelets. The platelets have many agents that can stimulate both coagulation and inflammation. But in a flowing environment, we wash downstream a lot of these and dilute a lot of these factors. So I think the important thing is to prevent the platelets from releasing their innards, if you will, their dense and alpha granules full of these cytokine components. And again, it's something else we think we see with these polymers is they do prevent the release.
Thank you so much. This was really very interesting, and I learned a lot. So the next speaker is Alok Finn, and he is going to speak on preclinical evidence of drug-eluting stent performance.
Great, thanks. So I'm going to talk more from the preclinical practical aspects of what Dr. Ratner discussed and show you some aspects that might be more applied. This first slide goes over the history of percutaneous coronary intervention and really just shows you that we've come a long way. I mean, although we think that we are pretty advanced, we've come a long way in terms of developing products for interventions. We started with POBA, bare metal stents, first generation drug-eluting stents, and now second and third generation drug-eluting stents. We've gotten to the point where we have so many choices and the science has advanced so far, we need to understand that science. This is the current landscape of DES, thick strut polymer-coated stents. You can see I've divided into the durable polymer-coated and the bioabsorbable polymer-coated stents. The durable polymer-coated stents are Wijns and Resolute. The polymers are PVDF, the one we talked about, fluoropolymer and BioLinks on Resolute. And the bioabsorbable polymer-coated stents are given here, usually PLA, PLGA coating, all have thin struts, all made of current generation metals. The fundamental questions for this talk are all polymers the cause of poor DS outcomes. Are polymers a bad thing, or are they a good thing, or what are they? Are vascular response to all polymers the same? Could some polymers be beneficial? Will returning a DES to a bare metal-like state, that is a bioabsorbable metallic stent, lead to better outcomes? Let's discuss some of the evidence. So the concept Dr. Radner introduced was one of fluoropassivation, this idea that fluorinated surfaces really bind albumin highly, and that elicits a decreased local thrombotic response, and some say a faster rate of endothelialization. This is the preferential absorption of albumin, really is key in this, and that's preventing fibrinogen binding. That's what leads to this minimizing of platelet adhesion and activation and leukocyte and prevention of leukocyte recruitment. So we can test this idea in preclinical models. And this is, again, this idea of albumin. He showed this albumin binding. You elute it, and it stays there. Stainless steel does not have that same characteristic. And look at monocyte adhesion. The PVDF membrane, less monocyte adhesion than stainless steel. So we can make an arteriovenous fistula in the porcine model by connecting the artery and the vein with silastic tubing, place 3 stents in line, different stents we want to test, and run this at low ACT, give heparin low ACT, and look at the stents, examine them for the amount of clot they have collected. You can see here 3 different stents collecting different amounts of clot. We can stain this clot for platelet markers CD6142B, as well as inflammatory cells. If I was going to prove the concept of fluoropassivation to you, I would have to make a fluoropolymer-coated only stent and compare it to the identical bare metal stent, and I've done that here, and you can see we've stained platelets in red. You can see what a difference the fluoropolymer coating makes on the fluoropolymer coated stent versus the bare metal vision stent. Essentially, very little platelet accumulation on the fluoropolymer coated stent in red, whereas the bare metal stent has lots of platelet accumulation. And when we look by SEM, we see the same thing. We look at the Wijns surface. It's very smooth. There's almost no adhesive platelets, whereas the vision has lots of platelet aggregation. And we studied this in competitive drug-eluting stents. We compared Wijns to 4 bioabsorbable polymer-coated DES that are currently used. And you can see what we saw was, the platelets now are standing green. I apologize for the differing colors. You can see each of the bioabsorbable polymer-coated stents collected some degree of platelets, much more than Wijns. So no matter which way you counted it, entire area or stent surface area, Wijns performed the best in terms of platelet adhesion. We then looked at Ultimaster, which is another bioabsorbable polymer-coated stent. You can see there was generally less collection of platelets on Ultimaster, but the least on Wijns, and that's shown here, and the most on Vision. Number of clots was similar, less on Wijns, middle on Ultimaster, most on Vision. You can see we also looked at inflammatory cells. Ultimaster collected more CD14 monocytes than Wijns, and the most were seen on Vision. Now, BioFreedom has got a reputation for being a short-dapped stent, 1 month. We wanted to look at its thrombogenicity. You can see here in this same shunt model, it performed very poorly. Platelets are stained in red. You can see BioFreedom performed extremely poorly, had lots of clot formation on it, even more than the bare metal stent Vision, and that's shown in the quantitation on the right. And you can see the PM1 neutrophils also were collected on the BioFreedom, hardly any on Wijns, middle for Vision, and you can see that shown here in green on the confocal microscopy. Number of CD14 positive cells, monocytes, again, same story. BioFreedom the most, Vision next, Wijns the least. So the overall design of Wijns confirms acute thromboresistance relative to contemporary DES biodegradable coatings. The fluoropolymer-only stent had less platelet accumulation versus bare metal stents. There was less platelet accumulation on Wijns versus all these biodegradable polymer-coated stents, and also on BioFreedom. I think these data lend support to the reported clinical findings of lower rates of early stent thrombosis with Wijns. So what do we know about healing with Wijns? That's another question. Let's look at Wijns versus competitors. You can see we used a rabbit model here. We compared Wijns to Synergy, which is a biodegradable polymer stent I'm sure you're familiar with. We looked at 14 and 28 days. Animals received BRDU for cell proliferation, and we stained it for an endothelial marker, VE cadherin, as well as for macrophages. In terms of healing, the VE cadherin is shown in green. You can see there was really no differences in endothelial coverage at 14 and 28 days between Wijns and Synergy. The amount of cell proliferation was also, endothelial cell proliferation was also not different between Wijns and Synergy. So essentially equal endothelial healing. When we looked at inflammation, however, was a different story. That's shown in red here. You can see there's more inflammation in the Synergy stent, both at 14 and 28 days. Shown in this red, there's hardly any in the Wijns. Those were significant or borderline significant at 14 and 28 days. Our human data also show this good rate of healing for Wijns. You can see, compared to our human database of first-generation DS, Wijns performs very well, 4% rate of late stent thrombosis, consistent with your clinical experience. When you look at neointimal thickness over time, Wijns performs the same as first-generation DS, no matter what time point you look at in human autopsy models. What the prevalence of uncovered struts, that is healing, is significantly better for Wijns versus first-generation DS, no matter what time point you look at. Greater than 1, less than 3, greater than 3, less than 9, or greater than 9, less than 36 months, you can see the healing is far superior. And in terms of overall autopsy findings, uncovered struts was significantly better in Wijns versus first-generation DES, whereas neointimal thickness, the intimal suppression was exactly the same. Inflammation score was less than Wijns. Eosinophils per strut was less than Wijns. Struts with fibrin were less than Wijns, all conducive with better healing. So in summary, endothelialization and inflammation, synergy versus Wijns. I think endothelialization was similar between Wijns and synergy, though inflammation was simply less in Wijns and synergy. And in the human autopsy experience, first-generation DES versus Wijns, first-generation DES, Wijns demonstrated equivalent or superior intimal suppression with significantly better strut coverage, endothelialization, and lower inflammation in human autopsy specimens. And when you look at the Wijns polymer, another aspect you need to examine is the durability of the polymer, the adhesiveness of the polymer. Does this adhesiveness last or does it delaminate? These are different samples shown from autopsy specimens, 59-year-old male, duration 5 years, 73-year-old male, duration 7 years, 60-year-old male, duration 5 years. You can see in each of these specimens, the polymer is exactly wrapped around the metal without any evidence of delamination, showing you again another important quality of that PVDF, HPF polymer. So in summary, I think I've shown you Wijns' overall design is associated with acute thromboresistance with respect to platelet aggregation relative to contemporary DS with biodegradable coatings in our ex vivo shunt model, which I think is a good model to look at acute thromboresistance, and lends support to reported clinical findings of lower early stent thrombosis. The endothelial coverage between Wijns and synergy was almost identical. Neither one had an advantage. There was less inflammation above struts in Wijns versus synergy at 14 and 28 days. And I think that I showed you human autopsy specimens of Wijns showed significantly enhanced endothelialization compared to first-generation DES and long-term stability of the polymer. Thank you.
The paper is open for discussion. Any questions from the audience?
Fantastic presentation. I mean, very impressive results, both in sort of the preclinical basic science arena and also sort of the autopsy setting. We are all aware of the kind of limitations of preclinical data or bench studies, whatever you want to call it, and its sort of translation in human, in patients, basically. I was just wondering, I don't know whether, I mean, you'd be able to answer it. Is there an equivalent way of testing it actually in patients, short of going to the autopsy kind of level? If you had a blood sample prior to implantation and a blood sample, say, at 9 months in a patient, are there particular markers of inflammation, platelet activation that you have encountered that would be beneficial and give us a surrogate marker of what's happening inside?
I mean, you know, you can do flow cytometry to look at systemic platelet activation. Markers like P-selectin would be useful. The real question is, would you see those markers, systemic markers, if there was local activation on the stent? And I don't believe you would, especially at 9 months. I think it'd be hard to say that. OCT can give you some idea of how much thrombus is on the struts, especially in case of ACS long term. You know, I think people have studied 1 and 2 month data with Wijns, but I don't know how sensitive that data is. So I don't know what the panel thinks. I don't believe there's any really good sensitive marker that would give you in a systemic, using systemic blood, the local reaction occurring within the stent.
Make a comment on this. There's a lot of studies that have been done in left ventricular assist devices, artificial hearts and such. And one researcher, his name is William Wagner at the University of Pittsburgh, has taken long-term studies in calves with left ventricular assist devices and demonstrated that he can measure continually elevated levels of a variety of markers for thrombotic reaction, inflammatory reaction. The big difference here, of course, is that's a very large surface area device. And with the stent, I don't know if we could do that, but in principle, your comment is good.
And the circuit is large. I mean, that's a large circuit to go through.
Yeah, because even if, I think in animal models, the degree of injury is so much superior to what we do that, obviously you can see huge changes in P-selectin or any other marker.
I mean, I think the best we do have, Dr. Palmieri will discuss this, is we do have clinical data supporting lower rates of stent thrombosis in multiple analyses. So I don't think that is the preclinical and the clinical do jibe in that way.
But I think part of the problem is you can't really test it in humans simply because you're doing injury. So you're not just putting a stent in, you're at the same time causing injury. So the question is, are you causing equivalent injury? I don't believe so. I think it varies from patient to patient. So I think to measure systemic levels to tell us what's focally going to occur in the artery is going to be very difficult.
You're also anticoagulating. You know, all these people are on DAPT. They're getting heparin. They might be getting 2B3A. This is just a complicated, I think, thing to analyze. Yes.
Thank you.
You sort of mentioned it in some of the autopsy studies about the integrity of the different polymers. So I guess this also depends on how aggressively we deploy them. If you see some of these kissing techniques going to the struts, etc. So is there any difference in the polymers, like the methacrylate for the Cypher, the SIPs, or the Taxus, and this one, fluoropolymer fuchsine?
I didn't show you the data. I didn't bring it in this talk, but we did study the delamination of the Cypher polymer in this study. And in about 40% of samples that we looked at, we saw delamination of the Cypher polymer. So it definitely did occur. And I think the issue, the question I have in my mind, in addition, is when you do all these things, crushing and all this sort of stuff, especially with the biodegradable polymer stents, how much integrity are you getting of the polymer in those situations? I think it's a very good question, and I wonder sometimes. Or when it's heavily calcified and you have to force it through with a guideline or all these kind of things.
So you showed that as compared to the Bermeta stent in your model, the Wijns has lower rates of stent thrombosis and even lower inflammation. But now if you look at neotherosclerosis, Wijns has definitely less neotherosclerosis as compared to first generation drug-eluting stent, but more as compared to Bermeta stent. Do you have any data that shed light on the mechanism of neotherosclerosis?
Yes, I do. I mean, I have data in preclinical models to give evidence that, in fact, what's causing a lot of the problem is endothelial dysfunction caused by the drug. The drug itself loosens the junctions between endothelial cells, makes them porous, and that allows materials to come into the neointima that otherwise wouldn't be there. So I think a lot of the culpability for neoatherosclerosis ends up being the drug itself. And don't forget, no matter which stent you look at, these are drug release kinetics that are about at least 90 days. And maybe longer, and the tissue indwelling is not clear how long that goes. So I think, if you ask me, that's the primary mechanism that's occurring.
Go ahead.
You have shown the picture of the biofreedom stent where you could see very much thrombosis in there, and what I was wondering is the company of biofreedom, they it's part of their advertisement to say you only need 1 month of double antiplatelet therapy, and I think this is pretty shocking to see that there's so much thrombosis in the stent. And shouldn't it be better to treat the patient longer than 1 month, as the company says?
I mean, I think your comments are right. I think we have to look carefully at the biofreedom trial in the sense that the rates of stent thrombosis overall were high, 2%, or on the range of 2% in the bare metal and the biofreedom group. There's 2 characters of biofreedom I didn't discuss, which is one is stainless steel, so it doesn't have the same qualities as a fluoropolymer, and it actually will bind fibrinogen, I believe, preferentially. And the other is the strut thickness of biofreedom. It's about 129 or 120 micron strut thickness, significantly higher than Vision. that can cause hemodynamic shear abnormalities, platelet activation. So those two characteristics may play a role in what you're seeing in the preclinical model. And I do agree with you. It is shocking that that's the data we have, and yet 1 month of Plavix, according to the studies, is enough. I question that myself. I think Dr. Palmieri may bring that trial up and dissect it a little bit further in the next talk.
If there are no more questions, I think let's move on. We could have a discussion after all the presentations. So the next presenter is Dr. Palmerini. He's going to speak on clinical evidence of drug-eluting performance.
Thank you very much. So we have many drug-eluting stents nowadays in our cath lab, and I think all of us, as interventional cardiologists, have in mind this question: are there meaningful differences among second-generation drug-eluting stents? And I am probably right if I answer that most of us would answer no. There is no significant differences between different drug-eluting stents nowadays. They are more or less similar. But we have to acknowledge that this answer is an opinion. It's not based on evidence, on clinical data. And this is because we may agree on the fact that it's unlikely that there's going to be differences in mortality between different drug-eluting stents, but there are other important endpoints, like myocardial infarction and stent thrombosis, in which these stents may differ. Now, if you want to focus on stent thrombosis, and if we assume a 1-year event rate of 1% and relative risk reduction of 50%, we would need 13,000 patients to address this question. And we do not have such a large trial around. But on the other hand, we are positive on saying that there are some evidence for some stents which we cannot extrapolate to others. And this is because there is an imbalance of the research that has been devoted to this drug-eluting stent. So we have one stent, which is the Wijns stent, which has implanted in almost 20,000 patients in randomized trial. Then we have other second-generation permanent polymer drug-eluting stent, which are the Endeavor, which are the Promus, and the Resolute, which, by the way, have been implanted in 1/3 or 1/4 of patients compared to Wijns, if we consider only randomized trial. The first bioabsorbable-based drug-eluting stent is the Biolimus eluting stent, Nobori or Biomatrix, which has implanted in 1/5 of patients as compared to the Wijns. And then we have the Synergy, the Orsiro, or the Ultimaster, which has been implanted in just 2,000 patients, 1/10 of the patients that have received a Wijns stent. So it's not necessary to emphasize how numbers are important in this setting. With first-generation drug-eluting stent, we thought that coronary artery bypass surgery was over, and we know the end of this story. So we have collected all this data in a large meta-analysis, including 49 randomized trials and almost 50,000 patients. And we observed that at 30 days and 1 year, the Wijns stent had lower rates of stent thrombosis as compared to first-generation drug-eluting stent, some second-generation drug-eluting stent, but more importantly and unexpectedly also the meta stent. And you can see that this difference was already apparent at 30 days, a time period in which all patients are on dual antiplatelet therapy. And so the difference is related to the stent and not to dual antiplatelet therapy. Did we generate an hypothesis, or these data are real? Now, trying to answer this question, we have to understand what is a network meta-analysis. It's true, a network meta-analysis combines direct and indirect evidence, but this is a strength, not a weakness of a network meta-analysis. Because if you have only direct evidence, a network meta-analysis can be weak. A meta-analysis can also be inconclusive if indirect and direct evidence go in opposite direction. But indeed, a network meta-analysis is strong if there is consistency between direct and indirect evidence. And this is direct and indirect evidence for definite and definite probable stent thrombosis. And you can see that it's exactly the same. The estimate of risk of direct evidence is exactly the same as that of indirect evidence for definite stent thrombosis, and very similar for definite probable stent thrombosis. And this gives strong support to this data. How is that possible? We have learned in these years that having the polymer is something bad, because the permanent polymer is associated with chronic inflammation, chronic fibrin deposition, late malapposition, and neo-atherosclerosis. But now we have learned today that all not polymers are created equals, and that there are some polymers that are good because they are thromboresistant due to the property of fluoropassivation. So we are also studying this phenomenon in our lab. We have an in vitro system of stent perfusion, which is done by a peristaltic pump and silicone tubing in which we implant a stent. And now these are the result of some experiment which we have performed with the Vision and Wijns. Now this is a Vision and this is Wijns, and you can see by eye the large difference in the amount of stent thrombosis between the two stents. This is another experiment. This is the Vision and this is the Wijns. This is another experiment. This is the Vision and this is the Wijns. You can see that there is some variability in stent thrombosis between experiments, but what is not variable is that the Wijns stent is really clean. In the next phase, we are trying to dissect which is the property of the Wijns stent that compared to the stent is thromboresistant property. And this new set of experiment, in one tubing we put just the Vision, in another tubing we put a Vision coated with the fluoropolymer, in another tubing we put a Vision perfused with blood pre-treated with the drug, everolimus, and in the fourth tubing we put Wijns. So we are doing this experiment. These are just preliminary results, but this is what we get. This is Wijns, this is the Vision just with fluoropolymer, this is the Vision with the drug, and this is the Vision. So it's clear that most of the job is done by the fluoropolymer. But now a new class of drug-eluting stent has reached the clinical arena, which are the bioabsorbable-based drug-eluting stent. And now the question is how this new device compare with the permanent polymer drug-eluting stent. These are all the trials that have been performed with this new device. This is the good news, but the bad news is that they are all non-inferiority trials. And we know that non-inferiority trials have many limitations because they do not have power to address differences in important endpoints, such as mortality or stent thrombosis. They often combine heterogeneous endpoints, such as death, myocardial infarction, target vessel revascularization, and sometimes they have disproportional high non-inferiority margin. But worse than this, most of them turned out to be underpowered because there was an imbalance between expected event rate and observed event rate. Observed event rate sometimes being 60% lower than expected. And so this trial can be considered inconclusive. To gain statistical power, we performed this other meta-analysis in which we collected 51 randomized trials, more than 52,000 patients, in which we compared the Wijns stent with the mostly investigated bioabsorbable polymer-based drug-eluting stent, which at that time was the biolimus eluting stent. And again, we observed lower rates of stent thrombosis with Wijns compared to the biolimus eluting stent. And this is really consistent with recent data. These are Excel and Nobel. You know that in Excel, PCI was non-inferior to CABG for the composite endpoint of death, myocardial infarction, and stroke, whereas in the Nobel trial, PCI was inferior as compared to CABG for the composite endpoint of death, myocardial infarction, stroke, and target vessel revascularization. So there are many similarities and differences between these two trials. So of course, the primary endpoint was different, death, myocardial infarction, stroke versus death, myocardial infarction, stroke, and revascularization, and also the stent was different. The Wijns in the Excel, and mostly the biolimus eluting stent in the Nobel. And this is the performance of the two stents in this trial. The rate of stent thrombosis at 3 years with the Wijns in the Excel was 0.7%, whereas in the Nobel trial was 3.0%. And this is very consistent with the network meta-analysis that I've just showed you. But we have to acknowledge that, again, all bioabsorbable polymer drug-eluting stents are not created equals because they may differ regarding the stent platform, the strut thickness, the polymer, the time of polymer degradation, and the eluting drug. And now there is a new generation of this new device that have reached the clinical arena. We have O0, the Ultimaster, and the Synergy. In the bioscience, O0 was compared with Wijns, it was non-inferior to Wijns. In the Century 2, the Ultimaster was compared with Wijns, it was non-inferior to Wijns. Evolve 2, Synergy versus Promus. Synergy was non-inferior compared to Promus. And in the BioResort, Synergy versus O0 versus Resolute, they were all non-inferior. So again, the bad news is that all these trials are non-inferiority trials. And so, for example, in the bioscience, there was a 66% relative risk reduction in definite stent thrombosis with cobalt chromium everolimus with Wijns compared to the 0. Is this the play of chance? In the Century 2, the observed event rate was 60% lower than expected, and the non-inferiority margin was even wider than the observed event rate. In the Evolve 2, only 1,800 patients were enrolled. It's a too small trial to see whether there are risk differences in stent thrombosis. And in BioResort, again, observed event rate was 42% lower than expected, and the study population was 44% of eligible patients. So in conclusion, fluorinated permanent polymer, the Wijns stent, is the most investigated device ever, with 31 randomized trials and more than 20 patients randomized to this stent. Across randomized trial, meta-analysis, and observational studies, the Wijns has been shown to reduce early and late stent thrombosis, not only compared to other drug-eluting stent, but even Virmani stent. At median follow-up of 4 years, there is no significant advantage with biologic eluting stent as compared to the Wijns. Indeed, the Wijns stent was associated with lower rates of stent thrombosis compared to biologic eluting stent. New bioabsorbable polymer drug-eluting stent have been shown to be non-inferior to second-generation permanent polymer drug-eluting stent, but randomized trials performed so far have been underpowered to detect the difference in stent thrombosis or myocardial infarction. Thank you.
Like some questions from the audience?
Thank you, Tullio. You mentioned about the fact that the non-inferiority trials don't give you really the data that you need for those meta-analysis, whether it's conventional or network. Are you working on individual data with those meta-analyses? Would that help?
Well, actually, most of these meta-analyses were performed based on aggregate data. I mean, if you have 50 randomized trials, it's really tough, if not impossible, to get patient-level data. But of course, patient-level data are meta-analyses which have higher quality than aggregate data. I mean, it would be nice if we could pull together 50 randomized trials and do many, many analyses with all patient-level data. I think it would be great. Big data. Yeah.
But nobody will allow it.
Absolutely.
Go ahead.
Great talk. I was just wondering, it seems certainly from your conclusion that it does not appear that the presence or absence of polymer is the deciding factor in determining future risk of stent thrombosis. I'm just wondering if you then can apply that kind of idea to the BVS, the absorbed BVS, and what are your thoughts about whether it is actually we know that there's loads of factors that are influential in creating scaffold thrombosis in the future, but whether the fact that the polymer is breaking down, whether there's any evidence that it's the degradation products of it that are precipitating the risk, that precipitates sort of scaffold thrombosis in itself.
Oh, I think this is really a great question, but unfortunately, I don't think we have data to answer to this question. So what we can say is that looking at this data, there is no need to get rid of a polymer, leaving a Virmani stent, if a drug-eluting stent with a polymer is safer than a Virmani stent. But going into scaffold, it's a totally different story, because with scaffold, you don't leave anything behind. So I strongly believe in the idea. So probably what we need is to refine the devices, because the idea has a strong biological plausibility.
But I think you ask a question in terms of if it remains uncovered. That, I think, and as it's degrading, if it doesn't get covered with tissue, from what Dr. Ratner taught us, I would think this is much more thrombogenic. Wouldn't that be true? You know, totally bioabsorbable polymer, which you said were hydrophilic, and those hydrophilic are the ones which are much more thrombogenic. So if you leave it uncovered and you have such a thick amount, such a large amount of polymer, one, it is very thick. Second, it covers a large surface of the vessel wall. So the question really is if it is covered with endothelium, I don't think that's a problem. I think the question really is if it is not covered, then what happens? And I think, you know, you take patient off dual antiplatelet therapy. I wouldn't be surprised why it wouldn't thrombose.
We talked a lot about the blood compatibility, and maybe Tullio or colleague on the panel, what about the tissue biocompatibility, particularly over time? Is this fluoropolymer stable forever, or what happens once it's embedded in the tissue for years and years?
So I think that Alok showed great data about the durability of the polymer. So probably you want to answer this
I didn't show the data here, but we had shown, because of time, we had done a study, exactly what you're asking. We had looked at the long-term responses to fluoropolymer-coated stent versus Vision, bare metal stent, and looked at the inflammation around the struts. These were stents of 2 years age or greater. We actually found that the inflammation scores were higher in the bare metal stent than in the fluoropolymer-coated stent. So it just goes to show you that there are some aspects of biocompatibility with the fluoropolymer that are, I wouldn't say they're protective, but they certainly don't provoke long-term inflammation. I don't think we can say that with Cypher, for instance, but we can say that with this particular polymer.
And this is probably due to the stability of the polymer, because you showed in your study that there is delamination of polymer coating first-generation drug-eluting stent, whereas you never saw this kind of delamination with the with the fluorinated polymer, which looked very much more stable, right?
Yeah, we didn't see any delamination at all with the fluorinated polymer in that study at all, whereas we saw about 40% of samples had some evidence of delamination in Cypher. So I think that it does change your feeling about...
I think this is really a very important issue, because if we talk about stent thrombosis and thromboresistance property of the Wijns, we are thinking about a period of 30 days, right? Where most of the game regarding stent thrombosis is played, because 60–70% of stent thrombosis risk is within 30 days. But then it's also important then you have a stent which with different mechanisms, guarantee you safety and stability. And my understanding is that the stability and the absence of delamination of this polymer confer this property.
Yes, I would say that, but it's one aspect of the story. There are other aspects that we didn't discuss, like the endothelial health. How is the endothelium doing on top of that is not possible with these kind of studies, because we just do not have the resolution. Yes, part of the story is exactly what you said, but there are other parts that are not able to be shown easily in humans.
Go ahead.
My question is about in-stent restenosis of second-generation stent. Is it all patient-related factor, or whether the different stent material attribute to the in-stent restenosis? And second question is the different antineoplastic drugs on different stent. Does that have any effect on incidence of in-stent restenosis?
So, of course, the stent structure is very important in determining in-stent restenosis. For example, the thicker the stent, the higher the risk of restenosis. The geometry is also important for determining long-term risk of stent restenosis. So, of course, the drug is important, but I don't see a lot of difference between different drugs in terms of preventing restenosis.
I would say that the drugs, so they're all mTOR inhibitors, sirolimus, everolimus, zodorolimus, the olimus we're talking about. As you go from sirolimus onward to everolimus, other olimuses, the side chain modifications have been such that they are retained in the arterial wall better. So my personal feeling is that you may get better longer-term drug retention with newer generation drugs than you got with first-generation drugs, and that may make a difference in recent. I don't think it's ever been shown, but I think that there are differences in the way these drugs behave. And in terms of the metals, I would say that we do know that metals, another component that could lead to restenosis risk. You need metals that are as much biocompatible as you can get. We know gold is not a very biocompatible substance. We know that cobalt, chromium is fairly biocompatible. There is some leaching of metal out of that, and that may be one of the issues with long-term responses to metal stents.
If I may ask Tullio, I read your editorial, what is it called? Extraordinary claims require extraordinary data, or some, what was the title? Yeah,
Yes.
it's great. So you told us, you know, we can be confident that if you compare bare metal with durable polymer like the fluorocarbon, thrombogenicity is higher with bare metal. What about the difference between stents coated with bioresorbable polymers versus bare metal?
Well, I think you gave us a very nice example on how randomized trial should be done with the PROTECT trial. Okay, so the PROTECT trial is the only trial which is powered for stent thrombosis, and the hypothesis was demonstrated. It was a trial with 8,000 patients, 7,000 patients, which was powered for the primary endpoint. And you nicely showed that the hypothesis behind that. So my opinion is that this is the way we should go. I mean, do less non-inferiority trial and more trials which are enough powered to see whether there are significant differences in stent thrombosis, which is a very important issue to me. Because stent thrombosis means mortality, means myocardial infarction. Even though it is a rare, it's not going to impact on overall mortality. I think it's a meaningful endpoint.
Yeah, but as the delay of the event grows, increases from implantation, the clinical syndrome, stent thrombosis, becomes more and more heterogeneous and can mean many, many different things. So our sensitivity in terms of detecting the events or recognizing the events is low.
I agree.
Because there are many mechanisms.
Absolutely, absolutely. But again, as we have said before, 70% of stent thrombosis are early stent thrombosis. So probably if there is a difference between two platforms, two different drug-eluting stents, we are going to see that very early. But of course, there are many other mechanisms that play in the game.
I think when you look at the pathology data, at least I can tell you that there are still mechanisms that we don't understand. We certainly know neoatherosclerosis occurs, and it's irrespective whether, even in bare metal stents, we get neoatherosclerosis, maybe less and more in the drug-eluting stents. But I think we don't talk about drug levels. Drug levels play a role. Design of the stent plays a role. We don't talk about that. Strut distribution circumferentially, if a vessel is highly calcified, now you're putting a stent, you scrape on one side, you put more struts on one side, less on the other, you're going to get more restenosis. So maybe you can overcome this for the first year. But after the year when the drug is gone, we believe at least after a year the drug should be gone, even in humans. So I think, you know, it's not that simple, and I would like to know, if I'm a patient, I just don't want to know first year. I want to know, I don't want to live just 1 year. I want to live 10 years. So I want to know 10 years,
I agree,
which is
but
the stent I need.
Teasing out differences in late or very late stent thrombosis is almost impossible, because the risk of stent thrombosis or very late stent thrombosis is so low that you're not going to design a trial to see that. So what you should look at least is overall stent thrombosis at 3 years, 4 years, knowing that most of the game is played in the early phase.
Yeah. Yeah, but here then Steve Osterley will come and tell us, listen guys, big data, you know, there is millions of patients there.
Yes.
And if we would have all that data available and give it to a, what is it, cognitive computer, or how do they call it? Yeah, then we would be able to get the answer. And of course, with our traditional trial-based hypotheses and means, we don't get there. Maybe.
You're also drawing conclusions from all your meta-analysis, and you're showing us that 20,000 patients makes a big difference.
Yeah, absolutely.
But we do have good data from healthcare systems that are well organized. I don't know if the Netherlands is one, but some of these healthcare systems are collecting data on the whole population. And so we do know in some situations that is tracked, and those are useful data. I mean, it's not a randomized trial. The patients are different. There's a lot of complicating factors, but at least it gives you something.
So I believe
trials are expensive. I mean, it'd be great to do thousands of patient trials, but I don't know if it's practical in terms of expense.
But, well, I believe that 20,000 randomized trial with 20,000 patients is better than anything. Okay, because again, big data are important, but there are gonna be so much bias.
Money and how long will it take, and by the time it's out, the results won't be relevant. I mean, it's like a DAP trial. You know, half those stents are not relevant anymore.
Yeah, absolutely.
So are there still some questions? Yes. If not, let's go to the case presentation by Dr. Ferdinand.
Thank you, Dr. Virmani, and thanks to the organizers for the invitation. Let's see if I can play this. Well, we have come from the preclinical data, from the basics, preclinical data, clinical data, meta-analysis, everything. So I was asked to present a case to try and illustrate the importance of polymer in stents, which is mission impossible, I would say. So I tried to focus on presenting some case on the safety of stents. Let's see if you like it. This is a controversial case, of course.
Those are the best.
Yeah, I think so. So it's a relatively young patient, 56-year-old male, hypertensive, smoker, and hyperlipidemic, that was admitted with a lateral STEMI. So he was scheduled for primary angioplasty. He came to the cath lab with this marginal branch closed, quite a burden of thrombus there. But I would like you to look at the LAD from the proximal segment to the middle segment. You see there's something strange there, probably, I don't know, recanalized thrombus or dissection, healed or not, we don't know. Complex things, right? Because it's quite clear that the culprit seems to be the marginal, right? Another picture, better than the previous one. You see how ugly this LAD looks. Another picture. So we reinterrogate the patient, and he said he had an episode of chest pain before, like 3 years before. So we interpreted, I don't know if correctly or not, that the culprit lesion obviously was the circumflex, and that probably the other one was the culprit in the other event. So we proceeded to the angioplasty, primary angioplasty.
How was the right, if I may ask?
Right was a nice and smooth artery. Yeah, no collaterals.
No collaterals, no to the LAD, no to the circ.
No to any of those. Okay, it was a regular and nice right coronary artery, dominant. So we proceeded with the angioplasty of this circumflex. We passed 2 wires, one to the circumflex, one to the marginal. We aspirated. It's true that thromboaspiration is not very, it's not very fashionable at the moment, but it was a lot of thrombus. So we decided to go for it, and it opened the artery. The artery was now open. The patient was stable. It was not so easy because you see still a lot of thrombus there. So we implanted the first stent. We decided to go for a science 3 by 28 millimeters, trying not to cover the bifurcation, but we needed to put a second stent overlapping, 3.5 by 18. And what was expected happened, of course, that we closed the circumflex. So we had to recross. The flow was okay in the marginal. So we recrossed and did just a smooth dilatation with a 2.5 balloon to this circumflex artery. And after that, the result was reasonable. Patient was on ticagrelor and aspirin from the ambulance coming. And I think we gave him just 7,000 units of heparin. We didn't use 2B3A. We're not using it regularly. Maybe in this case would have been an option, but we didn't use it. So this is the result. I think I can play it again for you. So it's a lot of interventional cardiologists Small here. Branch. What do we do next? Do we do anything else next? On the table or not?
Is the patient having chest pain, or what's
No, patient was okay.
This is a small branch to me. I mean, that's the AV groove branch with a very small marginal. I'm not sure I think you fixed the major issue with the large OM that you fixed. Mm-hmm. I probably would be in favor of not wasting a lot of time. But I do think the LAD, something is very abnormal with the LAD.
I was trying to get you there more than to the circumflex is fine.
Yeah, I would rush to the LAD. Well, not rush, but I would
not rush, but no. Do we do anything or not?
I would image that.
Image?
I would use an OCT.
What do you mean image? OCT?
I would OCT it.
So you would do an OCT in a patient with a STEMI on the table?
I'd just be afraid that there's that sitting thrombus there that I think we need to, we at least need to know what's going on there. Okay. I mean, there's TIMI3 flow, so I'm not so worried, but I would want to know.
Okay. Mm-hmm. Okay, so we have two versions, right, of treatment.
Well,
we
yeah.
have a conservative and a moderate
Maybe a
risk.
colleague in the audience wants to give interpretation or suggestion.
Anybody want to?
No?
Anybody in the
Anybody in
audience?
the audience? No?
Maybe we could raise hands.
It's
Or
worth
leave it alone?
making a comment. What you think?
Go to the microphone if you don't mind. Yeah.
Yeah, I have to agree with the sort of the fact that you fix the culprit lesion. There might be something there. If your ST segments have come down and you've got this history that maybe there was an index event 3 years ago, you don't really need to rush and find out what's going on in the LAD. That doesn't mean you ignore it. You may well do a staged kind of procedure within the admission itself if you're a bit sort of wary about letting this patient go. But I think to actually go on and tackle something else after you've had a, you've had a closure of a side branch here, it's probably quite, that'd be the cautionary way of doing, cautious way of doing it.
Did the STs come down? But where was it elevated? I didn't see the ST elevation.
ST elevation was lateral. Was I think it was V5, V6, something like that. Patient was stable. ST was reasonable.
V5, V6.
Yeah, patient was stable. It's true.
And no chest pain, and the ST were
no
down.
much. I mean, it's a STEMI patient, so.
I didn't look at the LAD closely. There's no propagated thrombus in the LAD, right? There's nothing that would indicate that there's something.
You couldn't
going
tell.
on.
I mean, it's difficult to say. It's difficult to say if it does a thrombus, is if it is old or new.
Yeah, I don't know what it is, but I would just look for that carefully.
Well, it's a funny image, but what happened the day? Was it MI out of the blue? What happened the days before?
Out of the blue.
Out of the blue.
It's a young patient, 56.
Yeah.
And
But he's a smoker.
a smoker.
He became pain-free upon the circ opening.
Yeah. Sorry.
Sorry, he became pain-free upon opening the OM.
Yeah,
That's
he
resolved pain.
totally stable. Yeah.
I think it's thrombus.
Sorry, Giulio, go to the microphone, otherwise people don't hear you.
Or get a microphone.
You see, to me, it could be recanalized thrombus, but usually looks different. It could be a dual lumen, sort of a dissection with re-entry. I don't know the case, but...
So my interpretation of the angiogram and of the clinical case is that LAD has nothing to do with what happened. So that's the reason because I would ignore it. And that's the reason because also after the procedure, I would not bring back the patient because we don't know the clinical correlate of this lesion. So
I think you're totally right, but
I would be a little concerned about if the patient came back with chest pain in the middle of the night. You had just got finished. 2 hours later, you're called having chest pain. Would you just leave it alone?
I think I agree with both. Probably the...
You can't have it both ways.
Yeah, that's why I did something different. I mean, Dr. Palmerini is totally right. Patient is stable, so maybe you can stop here, or maybe you can stage the procedure, but they asked me to bring a reasonable case here, right?
Yeah.
So we imaged
all right.
the damn LED. So you have it. Look how nice that is.
Now you know. Now
So
you know.
we are coming from distal to proximal for people not very familiar with OCT, and you see a lot of microchannels. This is quite spectacular, I have to say. You have still pictures on the right. No thrombus apparently,
beautiful. Yep.
but it's quite nice, isn't it?
Beautiful.
It is 60 millimeters, I think. If you go, I don't know if I have it here. Yeah, 69 millimeters. So even worse than we were, because what now?
It looks like the
I
Eurotunnel.
wouldn't do anything.
Yes.
It looks like the Eurotunnel, yes. So now, do we do anything?
I would leave this alone. I think you've proven that this is chronic recanalized CTO and that there's no emergency to do anything, or recanalized thrombus. There's no emergency to do anything, if you ask me.
Dr. Palmerini, what would you do? Would you do anything? You're right, but you are an interventional cardiologist, aren't you? Yes. You are on the table, and you see that, and you are telling me that you don't do anything? I don't do anything. For sure?
Yep.
Okay.
You could do something now. Later is what I was thinking.
Was it
Later.
easy to wire? Because very often recanalized thromboses are not that easy to wire.
Yeah, it was not so tough to wire because we wired.
Because they're large.
Yeah, we don't know which wire, which channel we used, but we wired it because we couldn't resist the impulse. I agree totally with all the things Dr. Palmerini is saying, but we did it. I will show you, please.
But the reason I would not do anything, and I agree with Dr. Palmerini, is remember there's good flow.
Yeah, it's
So
true.
why should you touch this?
Would you do
This is
FFR?
nature has done it for you.
Would you
So
do a FFR or something?
I don't even need
wouldn't.
an FFR.
Okay, but you will be even more right when I show you the outcome. So we wired a patient. Well, we are very comfortable using science in lung stents, in lung lesions, because we had, apart from the small sample of 20,000 patients that Dr. Virmani has shown, we have around registry in 3 countries with 600 patients in Germany, France, and Spain. Lung lesions, you have here more than 600 patients, more than 700 lesions. Stent length more than 34 millimeters, sorry. And 2 years follow-up is really impressive with a total MACE rate of 5.7 and TLR is 2%. So we are very comfortable using science in long lesions. So we decided to go for a science, and we use a very long one. We pre-dilated because we were not very sure. I think, in fact, I don't remember exactly, but I think, in fact, we tried to pass the stent directly, and it was impossible. So we dilated with the same delivery system that we have used before for the circumflex, and we put a science expedition, 3.5 by 48, with this nice appearance. The circumflex is still okay, some thrombus, but still okay. Patient was fine. So we imaged again, of course, after this, and I will show you. You see the long view anyway, which is nice, but still a lot of channels around the stent. I will show you in a second. You have it in the still picture on the right-hand side of the slide. We're coming now to the place, but it looks reasonable, right? I mean, lumen is good, the position is nice, stent is quite round, but we had a lot of small channels, so we decided to go for post-dilatation. This is the looks of the angio, by the way. You see the channels there, actually.
Yeah.
So we decided to go for post-dilatation with a 4 millimeter balloon, NC balloon. We didn't go very distal to avoid dissections. That's why I'm going to show you now the second picture after post-dilatation, that distally there are still some channels, but now it looks quite nice, to be honest. The stent is very, very expanded, well opposed, and I think the result is pretty nice. Distally, there's these channels here, but all the middle segment and the proximal part is quite nice. I will wait for the run to finish. Okay, well, we have our patient solved. Patient did well, circumflex treated, LAD treated. So this is the final angio. The flow in the circumflex is not so good, but patient was doing well. So he was in the hospital for 3 days, I think. We performed an echo. Echo was okay.
What stent was that you put in the LAD? What did you put in? Science.
Science, okay. Yeah. It was a science expedition because there's no 48s with the new Alpine. Okay. So it was science on the circ, science on the LAD. These are the medicine patient was taking after release. Everything okay, right? But it was not. 3 months after, the patient comes back with hematuria, and the urologist diagnosed a bladder cancer. 3 months. So he told us that he needed to perform some kind of operation. Don't ask me which one. But he needed to reduce the dual-antiplatelet therapy to 1, aspirin probably. And he came with the case to us. So what's next? We made the decisions that we made. So now we have to face the consequences, right? So
we have stent thrombosis.
I think you're 3 months. I think your 3 months is okay. I think you're in the minimum, to me, amount of DAPT you need for these type of stents. I think you're okay.
If it is
but
1
you
month,
remember he had an ACS. He presented with ACS.
And a lot of thrombus and a long lesion on the LAD.
So let's ask Tullio. I mean, meta-analysis, 3, 6, etc. From the microphone, please. Yeah. How many tens of thousands do you have?
So in this case, what I would do, try to convince the surgeon to operate the patients just on aspirin. Of course, you cannot do surgery with double antiplatelet therapy. We know that urological surgery is associated with high risk of bleeding. But now, if you interrupt dual antiplatelet therapy for 5, 6, or 7 days, the risk of stent thrombosis is high. Okay, and now you have 2 stents. One reason more not to do anything for the LAD, because now if you have stent thrombosis, you're going to have stent thrombosis on the LAD and on the circ.
No, Tullio, that's not the question. Now you're trying to prove that you were right not to do anything on the LAD.
You were right from the beginning.
What we want to know is what are the randomized data, pooled analyses, meta-analyses on 3 versus 6, 6 versus 12, all of that.
Yes, so what the data show is that the longer you do dual antiplatelet therapy, the lower the risk of myocardial infarction, okay? But on the other hand, the longer you do dual antiplatelet therapy, the higher the risk of bleeding and probably mortality. When I say long, I mean more than 1 year. Because if you pull together all the data of trials that have compared 3 or 6 months versus 1 year, there's not going to be a lot of difference. So probably 6 months or 1 year is not enough time to see a difference, okay? So if you want to see a difference, you have to go very, very long. So for this reason, but in the trials, most of the patients were stable patients, were not patients with ST segment elevation myocardial infarction, who have higher risk of stent thrombosis. But then you have to implement all this knowledge in the case you have. So we agree that this patient is at high risk of stent thrombosis up to 1 year. But on the other hand, if you cannot postpone the surgery, I think the best compromise is to continue on aspirin and try the surgery.
Do you think any type of picture that we can take can help us or not?
Angiography?
Anything?
You could OCT it.
You can OCT
and
to see.
And what?
I don't know if the OCT is going to be sensitive enough to show you for sure that the struts are covered.
Not for sure, but we have a lot of studies trying to link the 3-month OCT to clinical event, right?
Yeah.
So do we go for an OCT or not?
Well,
before operating the patient?
So please don't ask me again if I'm an interventional cardiologist, because I will do anything here, okay? So because again, the data are not enough to take decision on imaging, okay? You don't know how's going to be the prognosis based on imaging. So this data, the study you mentioned, I mean, you made a great point, but the study you mentioned are not enough to take a decision. And so all the data you have are based on clinical data, not on imaging.
Would you be more comfortable or not having a good OCT? You wouldn't?
What's your criteria for the coverage of struts? You know, what micron thickness are you going to use? What's the threshold for coverage? You know,
and what is it?
Yeah, I mean, that's
it could be fibrin rather than endothelium.
So I don't think there's a clear. You know, how are you going to interpret everything? That's very complicated, I think.
Can you put yourself in our shoes? I mean, it's not easy, is it? It's a young patient. He needs an operation. We put a lot of stents.
Go ahead.
Don't feel guilty. He had an MI.
No, I don't feel guilty, but we have to do something, right?
Yes.
I think you have a situation where you have a high risk of stent thrombosis, where you're going to block off 2 vessels perioperatively. And if you reduce to 1, the risk is going to be higher. So I think the best option would be withdraw ticagrelol for a week. Then maybe the 3rd day or something, start a heparin and intravenous tirofiban for 3 days, stop it before surgery, and cover again with the same after operation. I think that would be the safest, because there is a high risk at 3 months.
Okay, it is a high risk for sure, but we decided to go for something to, how do you say, to comfort yourself a little bit before sending the patient to surgery. The urologist was okay with doing the patient with with aspirin, but we were not happy at all because it's a lot of stents. And I would like to show you the pictures that we took, because I think they are very good for this particular stent. You will see how amazing it looks. This is the angio. The angio still has some channel or something up there. You can see it on the LED. Look at the circumflex now. Look at the circumflex, flow is normal, and all the branches look nice. But look at the LED on the OCT. Look at the struts all covered. some channels, the ones we see on the angio, but looks pretty amazing to me. I don't see. It's true that we didn't do a very thorough assessment of the coverage, but it looks pretty nice. This is the proximal part, and then the proximal LED. Here you are a comparison of the basal and the follow-up pictures. Same, more or less the same places. Channels are kind of blocked, and the coverage. I'm not an expert, but coverage looks pretty good to me. So we sent the patient finally to surgery on aspirin. He did well, and we didn't put ticagrelor again after the surgery. It's been 2 months now, and patient is doing well. So as a conclusion, I would say that the more complex the anatomy, the more efficacious and safe DES is needed, that's for sure. In this kind of prosthrombotic environment, safety is particularly crucial. Maybe the safest way wouldn't be not to touch the LED at all, that's true. And increasingly often, patients need to interrupt during interventive therapy. This was a young patient, but we have more and more older patients. Science has proven repeatedly low rates of stent thrombosis, Dr. Palmerini showed that. And he said several times, not all DES were created equal, right? And this is another phrase expressing the same thing. This is from Animal Farm. Probably the sense is different, but all animals are equal, but some are more equal than others. Thank you very much.
That was an excellent presentation and was a very interesting case. And I'd like to really thank you. It really involved most of us, even emotionally, perhaps. It was really good. I loved Dr. Palmerini's response. He was angry. He didn't want to hear anything to do with stenting in that lesion. So I'd like to summarize. I think we've learned a lot. I think fluoropolymers, there is no doubt, do passivate, and albumin really helps, and we should think about, especially in case that was presented, it was really very illustrative, that 3 months dual antiplatelet therapy may be the better way to go in patients who need surgery afterwards. So the second presentation were preclinical presentation, which was, again, we learned that, again, not all stents are equal, not all drug-eluting stents behave the same way, and that thus far, Wijns seems to show us better results, at least in your AV shunt model, as compared to bioabsorbable stents even. Then you also showed us data from the first few patients that were done at autopsy, and you showed that actually the amount of neointima and amount of inflammation is much less, neointima is similar, and the coverage is much better as compared to what the first generation drug-eluting stents were. And Dr. Palmerini, I think, was the highlight of the presentation, I must say, because I learned a lot from him, and I wish he had presented something on biofreedom, which was really a wonderful presentation, which we had this earlier afternoon from him. But he very nicely showed that patients actually each must be treated separately, despite his very many multi-center trials and putting together all the analysis that he's done. I think it really showed us that Wijns is by far the best from all the stents that are not only bare metal stents, but also some of the drug-eluting stents. It's the meta-analysis, that's all we can do. We cannot have large trials. So with that, I'd like to end, and I'd like to thank everyone for attending the session. And I'd like to thank Abbott and CVPath, Dr. Finn, for actually responsible for this afternoon session. Thank you.